I want to thank the Alliance for posing this question to our panel. What will the future of person-centered innovation be? We have two very big words in that one statement, both person-centered and what is innovation. And we'll spend a little bit of time because our panelists come from all sorts of different perspectives, which I think is going to make the panel even more exciting. And as the board chair for the Alliance, I want to thank all of you all for being here and for your support of the Alliance throughout the year, not just today. So with me today is Dr. Andrew Friedson, who's the Director of Health Economics Research at the Milken Institute. I'm just going to go through everybody's name and title. Adamika Arthur, who's the Executive Director for Health Tech for Medicaid. Daniela Lawton, who is the Assistant Director for Research and Analysis at the National Committee for Quality Assurance and CQA. And Kirsten Axelson, who is a non-resident fellow at the American Enterprise Institute. She's also a consultant at DLA Piper and Charles River Associates and the co-founder of the Preparedness and Treatment Equity Coalition. So thank you to my panelists in advance for being with us today. So our discussion is going to take 3 parts, and then I promise you we will have the full 10 minutes for Q&A from the audience. But the first thing I've asked our panelists to do is really start with, what is this term person focus to you from your perspective? So let's start with you, Andrew.
So the idea of person focused is that the people who are in the system, as opposed to the institutions in the system, have agency over how resources get directed. And I think that we tend to be, I'm an economist, we tend to be overly narrow in our focus, thinking about resources means money. And that's not what a resource necessarily is in the world or in care systems, right? That we want to be thinking about, are people able to have agency over how money is spent? Are people able to have agency over how information travels? Are people able to have agency over how time is used? That all of these are valuable resources that get spent within the system, and to what extent are your patients or your providers able to get a legitimate hand on the ball in how these resources are directed?
Great.
Well, I think we're at a point of productive tension in this word person-centered. We've used all sorts of different words, patient-centered, whole person care, et cetera, but I think we're at a reckoning, and I think that reckoning is because our systems and our structures in this country are set up to not be person-centric. I say this as an epidemiologist with a strong public health background who then ran hospitals for a long time, who now sends up an ecosystem around some of the most vulnerable Americans. And I know we often don't talk about we have a single-payer health system in this country, but I beg to differ that we do. More than 1/4 of Americans are literally on Medicaid. It's created a great system. It's all around the country, all 56 different ways in which it's done, and it has that other productive tension of a state and federal wrangling. So I think person-centered is challenged by the sense that we don't necessarily value all people. And I think we have to really start there with what does it actually mean for our systems and structures to be either broken and put back together, or how we reimagine what persons we want to focus on. And I think from a universal design perspective, when you think about equitable and inclusive design, and we heard earlier a bit around co-design, et cetera, the only way we can do that well is if we actually create the inclusion and exclusion criteria and be very honest about who we're including and who we're excluding as a part of that. And that becomes very challenging when you look in the context of health equity, because we do not want to say, we have built this system for a 1%. We have built this system for a able-bodied, cisgendered, white male over 65. We don't like to say that, but the best way to actually create a system is to make sure it was designed appropriately or redesigned.
Yep. Before I have Daniela weigh in as well, I want to circle back on 2 concepts. I know other panelists this morning have talked about this broad theme of when you think about person-first systems. I walked away from the discussion really reflecting on how hyper-local that means, whether it's hyper-local communities, or I love what my fam said, which is stop looking at averages, right? Averages mask all of the richness of what makes each individual unique. We also have to consider this as it relates to markets, right? The healthcare system is largely delivered by private sector actors, and many of the innovators that you'll hear about today are coming from the private sector, looking to serve different parts of the healthcare system. Andrew, when you think about markets, like how do you bridge between what you're talking about, people being able to direct resources and this definition of a market, and then going back to you, and like what makes Medicaid so special? And are you seeing people see that as a promising market? And then we'll go on to Daniela.
Okay. They give you a pause.
Because we focus so much in the United States on our market-based system, we need to have an understanding of what a market can do and what a market can't do, right? A market is going to innovate, but it's going to innovate in a way that serves the end goals of the actors within that market. So if you have a lot of power or consolidation in a market built into the providers or the hospitals, then innovation is going to push in that direction that pushes their profits. If you have a lot of power in the hands or resources in the hands of people and they have the ability to steer it, then innovation is going to move in a way that is going to serve the resources that they have to deploy.
Yeah.
So, if we are going to be operating within a market system and we want to have an outcome that it serves a person-centric worldview, then we need to have a world where resources are deployed in such a way that people can move them. That if we have consolidation of the ability to take time off, if we have consolidation of wealth resources, then this undermines the ability to have a more egalitarian growth model.
Great. And reflect on that when it comes to Medicaid.
Yeah, I mean, it goes back to the value change and the value proposition statement. And what you just talked about as it pertains to power and systems, we're in the negative in many respects, right? Huge number of people, 94 million people, plus or minus 6.5 million as of this morning through redetermination, which I'll get to later. Huge portions of our society, literally our family members, our caregivers are in our neighborhoods. This is what makes up our world in this country. I don't know a place in this country where you couldn't look to the left and look to the right and not have somebody be on Medicaid. In fact, many of our innovators in this country are on Medicaid as well, right? And so I think that in that value change analysis, I always have looked at healthcare from the perspective of that universal design element of a curb cut. How do we design the system so that everyone can cross the street? And I know that sounds, and I don't mean from an equality perspective, because I don't believe that equality is going to solve a lot of our problems, but from an equity perspective, for sure. Can young children who are learning how to ambulate cross the street? Can older adults with a cane cross the street, right? And you know, we've got the basic curb cut, right? And then we've got the really fancy ones with the auditory signals and the flashy signs, right? And that's how I think of our system of healthcare, right? We have to load, right, our system to make sure it accommodates. And right now we have a system where the power structures, the like everything is weighted on one side, and everyone is expected to use this system. And that's a little bit of what I said. I mean, I deeply care about the Medicaid population. People call me Madam Medicaid. I can turn any conversation into a Medicaid conversation, but mainly because it literally has made up how people that look like me in this country get care, right? It is there's a true historical element around, you would not have any physicians of color in this country has it not be for a system that allowed for them to see a patient population, right? So there's deep-rooted ways in which a 58-year-old system in this country is set up to be person-centered, because it is focused on people. But we don't have a system that really orients itself to that. So I hope that gave some depth and breadth. But I think sitting next to a health economist, it's very easy to have the blocks, but it's very hard to figure out what block you fit into well. Yeah. And I think that is the case for many individuals on Medicaid trying to access any sort of care in this country.
Yeah. So we've already touched on markets. We've touched on power structure. and for those of you that have been in Washington, you probably know well what NCQA does. And if we go back into the history of healthcare finance organization delivery, like the idea of accreditation and the idea of having an independent quality organization be able to provide information to purchasers of healthcare was a radical notion that grew out of this idea of both a recognition that the for-profit companies were going to play a bigger role in healthcare delivery, and that there needed to be a check and balance to accountability. So just with that very short history lesson, Danielle, like from where you sit today, NCQA has celebrated how many years now? What does it mean to be person-focused still?
Yeah, I mean, we use our quality measures really to identify that, and we have 88. They cover over 200 million American lives, and what they are is a tool to really provide a structured, standardized way to assess if an individual's outcomes and their experiences are aligning with the quality of care that they deserve. And it's allowing you to look at organizations and see what their processes are and how they can be adapted to make it more person-centered. I mean, for us, it's really bringing in the person and the individual at all steps. We have patient partners part of everything, part of our measure development, part of our panels. It's also talking to them and seeing what they really need to ensure that they're getting the care that matters most to them. And I'll probably talk about that in a little, but having measures that bring in the patient's voice and bringing that out and getting that into use and reviewing outcomes and patient experiences. That's how we're looking to see a patient-centered focus in the health system and quality.
Thanks. And Kirsten, you have been a highly renowned expert both on domestic and international life sciences pharmaceutical policy issues. I think there's no other sector in Washington that people believe has tremendous power. And at the same time, like you've been in an industry that really, from all the speakers we've had today, is very tuned in and focused on what does it mean to bring patient-first science to market, but what does that system look like? You know, from where you sit, Kirsten and I had this who in the audience saw Oppenheimer? Anybody see Oppenheimer? Really? Who saw Barbie? I gotta ask that. We have more people in a health policy audience that saw Barbie than Oppenheimer. I'm just shocked. It was so good. It is not what I would have thought. But one of the things, if you did see Oppenheimer, that just for me I reflected on is the science used to be seen as the hard part. And now the science is moving so fast, and it's almost like we don't think that's the hard part anymore. It's everything else. And so with that in mind, Kirsten, tell me how you think about this discussion around being person first.
Yeah. It's been the science along with the policy that has shifted drug development from one that was drugs that were developed on averages. We used to have, we had 6 different statins, we have a bunch of blood pressure medicines, and then the leading one was a combination of some clinical evidence, some marketing, some discounting. And the insurance companies were very good at getting the discounts and then steering people towards a particular blockbuster medicine that was for their condition. Advances in the ability to target medicines to a particular genome, plus the ability for the insurers to shift people to particular drugs, really got drug developers focused on more personalized medicines, more targeted therapies with evidence of super clinical value for particular populations. And that's rare disease, that's cancers with particular markers, blood disorders with particular markers, and that's really where the science has gone. Yeah. Now, the systems for testing, for reimbursement have not necessarily kept up with where the science has gone, nor have we done a great job at differentiating the medicines that are still out there and widely used that were these former blockbuster drugs. We've been saying the promise of real-world evidence forever, but why are we not mining the data to see which statins work best for which people or which blood pressure medicines work best for which people? We could be saving a ton of money by using cheap drugs better with the existing evidence we have. So I think the science has gotten more person-centered. The policy has not necessarily caught up to be more person-centered, and we're not harnessing the evidence we have to make the existing medicines more value to the individuals and the physicians who use them.
Great. So as you can hear, lots of different perspectives on this idea of person first, as well as innovation. I have asked the panelists to really think about, instead of talking in broad terms, help us all understand from where you sit, what is one thing that you've seen that you're excited about that not only works, because I think all of us have a lot of different pilots that we've seen work, but has gone to scale, right? Has really had the transformative benefit that it was originally considered to be able to have. So Andrew, why don't you start first?
One of the biggest resources is time, and I think that the thing that has opened up the most time for people to be able to seek care, to provide care, that has scaled well, that now is just part of our vernacular, is the Family Medical Leave Act, right? Prior to that, you could lose your job for taking time off, and now you can't. Like, I know that this is in many ways old news. It happened in the 90s. But if you want to talk about scaling something up that's going to make a giant difference in the ability of individuals to steer their own resources, you don't have to look any further than that. And we have other types of policies that are being debated, for example, universal paid sick leave, that are in the same type of vein of freeing up resources for patients to be able to steer, that allow people to make their own decisions about how their time is best used, and to seek the type of care that time and the ability to physically get to the place could be serving as a barrier for.
Great. And Amika, I know you have members doing a lot of great things. It's probably hard to choose your favorite, but if you could give us one example of what you've seen really be transformative.
I'm going to give you a theme versus
All right.
a specific company, partially because I think that there's still innovation that needs to happen, and we don't actually have the best lanes for policy for this work to be done quite well yet. One, I think, is in behavioral health strategies. I think a recognition that we need to have behavioral health as a part of our healthcare system. That should be health, right? What is health and wellness? It really does, it is mind and body and soul kind of thing, is huge. And I think that that's been pushed hugely through telehealth. And really helped from a telehealth equity perspective. And along the lines of using telehealth as a vein, the other thing is scaling up what we would consider to be differently functional workforce components of the healthcare system. And I'll use community health workers as an example. So if I use telehealth as a vehicle, the two areas I'm most excited about are promotoras and community health workers, or individuals that people identify with are not necessarily incredibly highly degreed and skilled workforce members, but are incredibly critical to understanding the translation between what health is. Getting drugs to a market is one thing, getting drugs prescribed is another, picking up those drugs is one thing, but taking them is something else,
That's right.
right? I mean, that sounds ridiculous, right? But we've spent our system on making sure the drugs are there, making sure that they're getting prescribed, making sure that they're at a pharmacy, but we actually don't do that last mile piece, which is the most important. Are you taking them? Are you taking them the right way? And do you know what it is that you're taking, right? And I think there is some scalability that really comes through that community health focused perspective around healthcare. And I think that also speaks to the sound body, mind, and soul component, because if you're not well, if you're not feeling as if you're in, it's Suicide Prevention Month, but if you're not feeling as if you're treated with respect and dignity, and you don't feel as if you can participate in this life, right? Which a lot of people wake up like that every single day. And I think we are now just deciding that we have to confront that as a nation. And I'm equally as excited that we're looking at different strategies and perspectives and innovating how we put behavioral health care into our healthcare system.
Great. Daniela.
So at NCQA, we've been developing a set of measures. It's called the Person-Centered Outcome Measures, and I will thank Maya. I don't know if she's here, but she brought them up earlier today. Always appreciate that. But so there's a set of measures where you're identifying what matters most to the individual, creating a goal, and then carrying that through care planning and following up on that goal and seeing, did they achieve it? What barriers got in the way? And really tailoring the care plan to that. So you're identifying that they don't need to have additional services because it doesn't align with what they want. And these measures, we've tested them with all different settings, all different clinicians, behavioral health homes, certified community behavioral health clinics, home-based primary care, serious illness, home and community-based services. We've kind of tailored it to everyone, and they're doable. And when you talk to the patients, the individuals that are actually getting this type of care, this approach of a clinician going to them and say, what matters most to you? Okay, let's look at what the care you're getting and how we can tailor it to that. the first thing they say, and we've talked to quite a few of them that are getting this approach, is no one ever asked me what matters most to me, and then followed up, and then asked, and then helped me get over those barriers to achieve that goal.
Yeah.
And the clinician, then we ask them, so what do you think? And of course they say, okay, it adds a little time. However, I mean, that's right, and you said time is, but they said it builds trust between them and that individual a lot earlier, and it builds that relationship sooner. Sometimes it could take 3, 5, 10 visits before you actually trust your clinician. When you have that kind of conversation, it brings the buy-in on both ways. And so what we're doing with this Measures to Scale is we're working with a state, and what they've done is incentivize their home and community-based service programs to get on their state-led health information exchange. Now, if you know, home and community-based service programs, they never can share their data typically. So if you're getting services there, your primary care provider has no idea until they get the
Right.
discharge form.
Yeah.
Because they don't have they may have EHRs, but they don't have the same EHRs that they could transfer the data across to a primary care specialist, things like that. So what they're doing is incentivizing them to update their systems to share that data on the health information exchange. And what they're using the measures for is to have those conversations about what matters most, get that goal on the health information exchange. So not only primary care and specialist providers, but all hospitals, they're all connected to the state-led
that's
health
great.
information exchange. So everyone can work towards that goal of that individual. And everyone has a different piece. Is it a physical therapist, a social worker, a primary care? They can all help that individual tailor the care they're providing to reach that goal.
So, in which states are doing this? Can you tell us?
I don't. No, I can't tell right now. They're quite big. Yeah, exactly. More to come. We'll be sharing that, but yeah.
But that's great.
They're
So
pretty
that-
large. Yeah.
Great. I love these examples because we've heard about how policy can be an accelerant. We've heard about how an event like a pandemic gives us flexibilities that we didn't even realize were so valuable to us when it came to telehealth.
Sure.
And we've talked about the role of data and the exchange of data to be able even to see a common set of what the challenges are at a person level. So I gave Kirsten a much more challenging question, which was, I was going to give her the same question, but then I was like, no, I'm going to give her a more challenging. So I want us to reflect in 2013, we all saw that there was a curative treatment that had been FDA approved for hepatitis C. And if you guys have been paying attention, the White House and Francis Collins, 10 years later, we need to eliminate hepatitis C. So the science was a decade old. We still have a problem. What have we learned from that case study? How can we not wait 10 more years for the next thing that could be transformative?
Yeah. One thing is we got entirely focused on the price of that drug, and all the policy was around the price of that drug. It was not around everything else that you need to do to get people in, tested, and treated. The price of the drug was big. The price of the drug came down by more than 50% once there was 2 of them, and once there was insurance coverage. People need to have insurance coverage. If you don't have insurance coverage, it's you against the drug company. When you have insurance company coverage, you have somebody acting on your behalf to negotiate and bring down the price of the drug and make it available on your formulary. We made policy entirely about, oh, no, don't get too many people treated because that drug is expensive, as opposed to making the policy about, let's get people in, get them treated, get the infection under control and not being transmitted because there's a long-term benefit. Those are small molecule drugs. We're going to be in a time where those drugs are going to be generic, the same way many drugs for HIV are now generic. That is extraordinary. You're going to be able to get treated for dollars a day, and it's just curative therapy. So we should have been focused on how do we get that curative therapy used and have our health system manage things over time. We're going to continue to see new innovation, and it's going to be a spike in cost, and then there's going to be a health benefit. If we're constantly focused on the spike in cost, the only reaction is going to be, don't use it. We have to face the fact that living longer is a good. Living longer has a cost, and we cannot live longer and get more years of life without paying for it. We can pay for it with some cost constraints, we can pay for it efficiently, but if we look at all these things as a bad guy as opposed to a good guy that can help us live longer at a cost, we're never going to see these diseases eradicated, and we're going to continue to have these fights even though we have great technology that can deal with the conditions.
Yeah. Okay, so then I want to bring us home in our last 10 minutes to the constituency that we most care about here at the Alliance, which is what can the policymaking community learn from each of your perspectives? So Andrew, starting with you, I don't think we have enough conversation these days about health in context. Like, what do you feel like is needed?
I think that the conversation today has been very focused on the healthcare system and ways to push it to be a better conduit for people. And the other way that you can be looking at this is, how do we empower people to be a better or a stronger group to be able to move through the system and to be better able to navigate it from the get-go, right? The idea that economic stability, economic security, wealth, these are all things that enable people to be able to move through the system better. And that the policy questions that we are very, very focused on are, how do we tune the system better, as opposed to these larger questions of how do we generate more broad-based economic security. And I think that these should be going hand in hand. On one hand, we want to be, treating a burn. On the other hand, we want to be taking our hand off the stove.
Right. Great.
I'm going to try to knit this together from kind of where you guys sit, right? Because I've kind of had the opportunity to be behind the vents in the four walls of a hospital system, being the person arm wrestling with insurance companies across the table to try to get rates down so we could see more people. But I think, to use an emerging disease as an example, using Hep C as an example, I think we need to step back. I mean, to remember that our value is in our people, right? And the largest economic indicator we have in this country is us.
Yeah.
It's us, right? So if we look at something like a cradle-to-grave program like Medicaid, right? The healthier we can keep our kids, the healthier adults they will be, right? The longer lived we are, right? So if we use something like Hep C as an example, Hep C impacts a broad range of people, but theoretically, it impacts a group of individuals who are not necessarily valued in this country. Mm-hmm. And that is actually why the price issue came to be. The price issue had more to do with who we thought deserved a rationalization of care, who deserved this drug at this cost versus not, irrespective of being insured or not, right? Medicaid is the largest insured population in this country. We're not talking about the uninsured, although we're kicking a lot of people off of the program, so we'll see. I think it goes back to the sense of value. And do we value each other, right? And if we go back to the fact that we have to operate together in an ecosystem to survive and live, right? So I think that going back, indexing back on empathy, right, on compassion, around service, around how can we create health as a measure to wealth. You talked about wealth creation, but if we don't think that health is our measure to wealth, we're really going to, we're kind of up against this structural component right now, where people are choosing, because of lack of trust, because they don't believe they're valued, they're just choosing to not participate in the system at all. That is not the answer, y'all. That's not what we want to see. And so I think it really does index back on how can we think of people first as being person-centered, not who the people are or how much they're worth, but really how do we get health as a part of our wealth creation component back into our vernacular. And I think that if policymakers look at it from that perspective, value-based care looks different, because we're valuing the people in our country as being that economic engine that will help us be better, healthier, more caring, with more ability to be able to survive.
Right. Yeah. So Danielle, these are
It's hard to lead up to, yeah.
Yeah, it's just, I will say, I think this has been such a great discussion, and I think everybody in this room understands, like, incentives are incredibly powerful,
Yes.
and metrics are really powerful,
Yes,
and
yeah.
what we publicly report is a big driver of how we see the world. Yeah. With what you've heard said, like, how do you think this changes or the perspective on where does measurement go? When some of what we're talking about is culture change, it's mindset change. Even the workforce discussion wasn't about how many FTEs.
Yeah, and with quality measures, I mean, we're starting to move towards digital quality measures, and what that means is really structuring and standardize the data so we can share it more broadly. So it's not only just for that one clinician, but it's for everyone. And what this does is decrease burden on the clinician for reporting out their data collection, and it also saves the system money, which can then be put back into that individual, and they can be getting the services that they really need. So the incentives are huge because everyone they need to get their systems up to be able to report these measures and share their data. And when you have that, you're able to save money, put it back into those individuals, and grow the care that they really want.
Yeah. It also gives people, it puts people on the same page for the reality. It changes the conversation.
Yes.
Sorry to add that.
No, you're completely right.
So, and Kirsten, when you think about the state of the conversation right now, like how do you feel like we can move towards what you're looking for, which is a more robust conversation about the trade-offs that really we should be having as it relates to access and innovation and affordability?
We've gotten, because it's popular and it's become bipartisan popular, we've gotten so focused on hammering on the drug companies over price, which is like maybe satisfying and fun. We have an NIH nominee held up over drug company prices. Do we really want elected officials getting involved in science? Do we want them telling universities, you can't study expensive stuff? You know, that's cancer, that's rare disease. So if we could shift this conversation a little bit more towards how do we get these different actors aligned so that they're fighting with each other over price? I mean, one of the better programs, and it's got flaws, is Medicare Part D. It's available to every senior pretty much. Prices have overall been held down. There's changes to be made, but that's because they put all these different actors together, and the tension is there for them to fight with each other on price and access. But now, because we've made it such a wedge and so political, everyone's in their different silos, in their different corners. We're not sharing data. We're pointing fingers at each other. We're not helping each other figure out the right policy because it's popular, not because it's right for patients. If one of these political actors would start thinking about what's going to make people healthier and save money at the same time, that is actually doable, but it's not done by picking out one singular issue and holding up everything else on that.
Okay, I think you guys have had a lot thrown at you in the last almost 45 minutes. We're going to open the panel for discussion. Any questions? Okay, we got one question.
Yeah, Nathan May. I'm an MPH student at George Washington, probably talking to this, right? But I have a molecular biology background. Graduated with a bachelor's in science and biotechnology from Arkansas State University. Go Red Wolves! And this question is a bit broad, and it's directed at you, Ms. Axelson, about, as somebody who has a lot of experience with biotechnology, talking about increasing our competition between drug manufacturers, what is your opinion on the status of and the future of plant biotechnology for pharmaceutical projects and PMPs?
Oof.
Wow.
Highly technical.
Way to
sorry.
be innovation and patient centered. There we go.
Look, we have a system where there are more new drugs being developed. We've also seen a huge amount of investment in China and in other countries to be able to develop good medicines. You know, it used to be that the medicines that came out of China tended to be more generics. So I think as far as the capability to develop new drugs, it's better than it has been. You know, drug development decisions are a combination of science and reimbursement. So, you know, we've seen some changes in Medicare recently that are going to make developing the second drug for the same therapeutic area, even though it might be better, much less lucrative. And so that's going to affect where investment flows. And that's not just drug companies, that's also into academic centers. So, you know, I think it'll remain to be seen how we continue to see competition. I would anticipate we're going to see more single drug niche therapies being developed and less competition within classes due to some of the changes in policy.
Great. Do we have a question in the corner?
There's a question over there, too.
Oh, there's a question over there.
Oh, great. Sorry.
Hi, Clay Marsh, West Virginia University. So this was really a great panel, and you guys are all super smart people. But here's my question. So as we look at our own health system that pays twice as much as as the average westernized country health system, and looks at the outcomes where we have a 9-year reduction in lifespan versus countries like Japan, and almost a 10-year reduction in lifespan versus countries like Hong Kong. What is responsible for this? Because spending more obviously is not the solution. Is the problem the way our health system's put together? Is the problem our society and our lifestyle? Is it both? What do you guys think?
So just to quickly promo, our friend Andrew here has a new book coming out in October. Pre-sales are available called The Economics of Healthcare, A Brief Introduction. I'm going to have Andrew
Yeah, so this
that
is
question.
chapter 19. And the answer is we don't know. Is that we
very
have
unsatisfying answer.
we have, but you've listed the what I'd say are like 2 out of 3 top theories, right? We've got a few theories that fit the facts. So the facts are United States spends twice as much as the average industrialized country, and we get solidly middle-of-the-road health outcomes. You can pick any health outcome you want, look at the OECD data, you're going to find us right in the middle to bottom middle of the pack. If you look at the, some of them will be dead last. I guess that's not fair. So you can break it into a few different things. One is it could be that we have much worse lifestyle choices. One could be that we spend a lot of money on care that we get very little return on. Right? This is what we call the flat of the curve, that we spend dollars and we get almost no return on them. Another one could be that prices are way higher, that we're buying the exact same stuff, but we're just paying twice as much. There's other theories as well, but the long and short of it is we can't rule any of these things out, and it's probably a confluence of all of the above. That we are bad at a lot of different things.
Isn't one theory also that if you total the number of what other countries spend in social programs,
Yeah, another one is we have systematic underinvestment in our social safety net. Thank you.
yeah,
And we're trying to bifurcate them.
Yeah.
Like, we act as if our social system is completely different
Separate,
than
yeah.
our health system. And I always say, like, when people talk about SDOH, which I know it's now a fancy, smancy term, but for those of us
if
who've
we
been in
renamed it too.
I
if
mean,
we
I
renamed
just
it.
call it determinants of health, because it's more than social. In fact, right now it's more political than it is much anything else. So it's political, it's economic, it's environmental, it's ecological, right? These determinants that are impacting our health. And some of it, we really hate to, and I'm an epidemiologist, I love data, but we do not like disaggregated data in this country because it tells us stuff that we really don't want to address.
Or we don't think we can do anything about.
Well, I think we can do something about it, and I think people know we can do something about it, but oftentimes it's not politically savvy to do something about it. It is, we are misaligned in our incentives. And so I think that we're going to have to get back to that. So I hope that's chapter 20, but
That's the epilogue.
Yeah,
next book.
he'll contact
Sorry,
you
we'll
after
work on
this. Yeah.
we'll work on my follow-up
I'll do
content.
your forward, no problem.
Anyone else want to respond to that last question? It's a good question.
No, I agree. And then I think it's just access. I mean, the amount of people that don't have access to care, appropriate services, I mean, that can just cut off a quarter of the population. I mean, so.
Yeah.
And that's about value,
Yeah,
right? Because
exactly.
we let hospitals close. I
Yep.
mean, we're sitting in Washington D.C. We saw what happened when one hospital system
Yes.
closed, and where it closed, and why it closed,
And
right?
where those people went, yeah.
And I think we do this all across the country,
Yep.
and we wonder why we have the outcomes that we have. We have them on purpose. We have created the conditions for this.
Yeah. Kirsten, anything?
Nothing new.
Nothing.
No, yeah, no.
Okay, we probably have time for one more question. Anyone in the audience? All right.
Hi, Katie Kozlowski. Really appreciate this conversation. I think these are big problems that we're posing. I'd love to hear from you all what you think the first step should be and
Right, that was
what we
gonna be
should
my
do
question.
next. Yeah.
So that was going to be my question. I
Stole
think
it from you.
Kristen in one of the last panels talked about if you were king or queen for the day. But if you to wave the magic wand, and I'll start at the end.
Everybody has to have insurance.
Yeah.
Everybody has to have insurance. Like and it has to be decent insurance.
And to go with that, I mean, I just said it, access. If you don't have access to appropriate care, then you don't have anything.
So I think we have an opportunity right now with public-private partnerships that will maybe get us to having folks be insured and getting more access because we'll be able to mine the data in an appropriate way. But I think that right now when we look at the economics, right, of employer-based coverage and how that fuels privatization of care, how our public systems rationalize care throughout their ecosystem, and for those individuals who have no care at all, which is growing by the minute, I think we really need to get folks into a room and try to figure out how it is that we make communities healthier so we can create incentives for people to be healthy and therefore participate in the system that they have. Because there's reasons why people don't access care even if they have
Correct.
insurance, right? And so I think we really need to get to chapter 20 of the book, which really allows us to sit down at the table and really figure out if you're the largest insurer, if you're the largest employer, right, what is it that we could do together along with those individuals who have a trusted ear and their ear to the ground or able to say what some of the challenges really are.
Andrew.
I'll go the complete opposite direction. I've been very big picture this whole time, and I'll end on a very micro note. This is a room full of a lot of health policy wonks, a lot of people who work with data and work with analytics and roll up their sleeves and get into the actual programmatic details. And I'll echo a sentiment from earlier in one of the earlier sessions, which is when you're looking at your data, stop focusing on the mean, stop focusing on the median. Look at your entire distribution, because those are all the people that are in your entire data set. That seeing an improvement in your average quality of life or your average health outcome for the United States, we're bad there. That's the average.
Yeah.
Well, and that allows us to be person-centered, right? Because there's stories and there's
Within that.
human beings behind those numbers. And I think that's the one thing that we often forget. And I'm an epidemiologist, I love data.
You love
But
the average.
it is the stories and the people that really matter, I
Yeah.
think, in creating a more person-centered healthcare system.
Well, I'm going to take moderator's prerogative and also answer the question.
Please.
And reflecting on everything that's been said about power dynamics, around accountability, about having the right conversations. And then Andrew kicking us off is a person-first system allows the people to direct the resources. You know, I think so much of what we hear about today, whether it's climate change or healthcare, really depends on us having strong communities, like super micro level. And so as we think about making big changes, maybe the changes have to really start with these very micro communities and enabling them to have a voice in the process. Particularly in healthcare, when you look at every part of the healthcare system, is consolidation, more and more consolidation. Like the only counterweight to that is being able to have the voices on the ground be clear about what they're experiencing. So I want to thank the panel, thank you all for your patience, your last panel of the day. One more conversation, and then hopefully you guys will leave and have a great rest of the day. And on behalf of the Lions and me as the chair, I want to thank you for your time.